I'm going to be talking about a study we did on moral distress and the responsible conduct of community-based drug use research. And basically, I'm talking about community researchers and thinking about what our obligation is to them, as well as some of the distress that we may feel when we're interviewing people who have trauma or don't. So I did, the article that I suggest is one where one of my colleagues, Gayla True, is the senior author, and that's more of a qualitative article. And what I'm going to be talking about is a little bit more about the more quantitative aspects. But anyhow, who are the community-based researchers? And this was community-based researchers who conduct drug use research in communities. 30% of them are also doing HIV and drug use research. So who are they? They're the research team members who live in participant communities or share participants' lived history of substance use, and have direct contact with participants through recruitment, screening, enrollment, intake, informed consent, interviews, focus groups. So we wanted to understand what it was like for these research team members who have this direct contact in the community itself. So what is moral distress? Now, moral distress came out of the nursing literature. I'm going to admit that the way this PowerPoint is constructed, it looks like I knew what moral distress was when I started this study. I had no clue. We did I'll show you that we did a focus group, and I'm trying to figure out what's going on with these people. They seem stressed, and they seem like they don't really like what they're being asked to do, and they're having problems. And then I kept going on Google trying to find something, and they've read moral distress. There's an entire literature out there for decades for nurses who had to work with doctors and knew and wanted to do things that they felt were better for the patients, but couldn't because the doctors didn't let them. But I'm sure that's different now with the two doctors that we have in this room.
I let my nurses run the show.
Yeah,
a lot of times they know a lot more than I
do. Want me to do this? Absolutely.
You got an idea, call me, we'll make it happen.
But in general, it's feelings of anger, frustration, powerlessness, anxiety, and regret that arise when morally appropriate actions cannot be implemented due to institutional or other obstacles. And based on Faith's talk, I think, a lot of us may feel this way anyway when we're doing research and we know, like Tom was saying, there's systemic issues and we don't even know how to really study them. It's not the way we're trained.
I will say, this did start in the nursing literature, but it has permeated across into the health system science literature too, because a big source of moral distress for clinicians at all levels of practice is not being able to do what is right for the patient because of lack of resources.
Yes.
Or because of a system inefficiency. So I have someone in front of me and I know from my training what I need to do to take good care of them,
Right.
but the system won't let me do it in an efficient manner. And so that is
insurance won't
or they won't pay for it, or even if they'll pay for it, I can't get them in to see the person they need to see for 6 to 8 months, and that's we've got problems now. And so there's all these barriers that have come up.
But what's really interesting is people haven't done it for researchers. And my colleague, Adam Freed, who used to be
We're all like,
we miss
Adam.
him. Even Willie, the person that caters for us, misses him. So who's Adam? Adam is chair of the clinical psychology department in Arizona, so he's doing really well. But we do miss him. But he wrote about the frustrations of clinical graduate students who are working in hospitals and doing research, also with people who are depressed or have anxiety disorders, and because it's in research, they couldn't help them in the same way. So but if you look it up for research, I think there's maybe 1 or 2 other articles that exist on this. Okay, so we did, of course, an interview study to try to figure out what this is about. And it was very interesting because my colleagues, Gayla True and where am I putting? Alexandra, where am I? She's on our cab. Why am I breaking? Oh, Leslie, I'm sorry, no, it was an L. Leslie Alexandra. Yeah, so they had approached me, I don't know why, but they had a grant. But really, their grant was about things that the community workers do wrong. And so, we kind of, this became much more than it was, because we were really realizing that this distress model. So it was very interesting for this grant. Okay, so the aim of this part of the study was, what are the moral challenges faced by frontline substance abuse community-based researchers? So they had done another study, then they wanted to make it ethical, and that's why I got involved in this. The first method we ran 6 focus groups with an N of 36 with community-based researchers working on diverse drug use projects in New York City, Hartford, and Philadelphia. I ran the ones in New York. So here was some of the themes that came out. The emotional burnout. Sometimes I have to close out my emotions. Organizational pressure. There was this constant pressure to get the numbers, to get and that, as I'll talk about, that threatens scientific validity, because sometimes they're letting people in that they shouldn't. And it was so funny. So in the focus group itself, they didn't say that they would, kind of let people in that shouldn't. And then they all came over to me afterwards and says, "Oh, we let them in. We do this, we do," and it was really interesting. But talk about trust, it was very nice that I had established some kind of a trusting relationship that they would say that to me. So we called this moral practice dilemmas, and I must say I really don't know what to call it, because it's really when they're really talking about that they are pursuing, they're realizing that their actions are not necessarily in accord with scientific validity. We called it moral practice dilemmas, but I didn't really know what to talk about. So for example, confidentiality is difficult. I'm known as the HIV lady, and they would talk about this. So, how is, anybody comes up to me, everybody knows this is an HIV study. They did talk about their research distrust. And I think people don't talk about how the people that work for us may be as distrustful as researchers, especially when they're out in the community or part of the community. But I sometimes feel the people I work for are research participants. They talked about the organizational research ethics climate, and whether or not it provided research ethics training, and they all did. But it's like the city. Like it was so on a surface level, but it did not encourage them to discuss their ethical concerns. And then they talked about research commitment, which I'm not going to talk about as much, but we had a measure for that too. And they just were all committed. So they felt that the research they were part of could be exploitive. They thought that sometimes the validity was not right. They talk about, the inclusion criteria is that you have had to shot up, in the last 3 days, and they would say, but I know this person is, uses injection drugs, but it wasn't available in the community that week, so they were taking something else, but this person can't be in the study. And so that was another, challenge they had. The other challenge was, and I'll show you in the, more in the survey research, but, people would come to their house to ask them for advice. They became the resource, or people would ask them for money. They would give out their own money to people because they were seen as somebody who was part of the community but had more. And so you can imagine how stressful that was for them, and the moral dilemmas. And of course, I didn't have it in here, but some of them talked about the risk of relapse, because we may be exploiting them, because a lot of times for community drug use research, we ask people who were former drug users. And so they are asking these questions, they're constantly in the community. And, we had, someone who had actually relapsed, and I always had him come back and talk actually to groups. And then he relapsed again, so he's not coming back. But it was just, so we have to be very careful, not to exploit these people. So, national survey was 2, the second part of our study. What are moral stresses faced by community-based researchers working in substance use HIV research? How do they navigate dilemmas in which adhering to either social justice or scientific scientific values requires abandoning the other ideal. See, that's the dilemma, right? That you want to do science, but you want to do good social justice. And I think I mentioned before, this was something we face in the scientist-citizen dilemma. That I know we all feel we're never doing enough to really get at what's going on. And how are moral distress and moral practice dilemmas related to research mistrust and organizational research ethics climate? Okay, so we developed a number of scales. One was work-related moral distress. The other was moral practice dilemmas, research mistrust, organizational research ethics climate. We also had an organizational staff support items. We had research commitment, which I'm just not going to spend as much time. Everything was scored on a 4-point Likert type scale, disagree, agree. And so we had hypotheses that risk factors would be that there would be higher levels of moral distress, would be associated with more encounters with moral practice dilemmas, and that moral distress and moral practice dilemmas would be positively associated with research mistrust. And then we also felt that a strong organizational research ethics climate would be a protective factor associated with lower levels of moral distress, moral practice dilemmas, and research mistrust. So we had 108. So we emailed 188 investigators, and who were working currently had grants on substance use research, and asked them to forward a survey announcement to current or recent community research workers. And our inclusion-exclusion criteria was that they had to be in this kind of a position within the past 12 months, and that their job responsibilities had to include the direct participant contact. It was a web-based survey. We gave them $40 Amazon gift certificate. So we had 275 respondents. A third were male. You can see their, the typical age range, 35.7. Most of them were full-time, but even though they were full-time, I don't think I have it here, but they were all had other jobs. But their health insurance was pretty good. Around 23% had a history of drug use themselves. Most of them lived right in the research community. And they were college educated, but their income was between 30 and 40,000, which was not a lot if they had a family. You could see, the majority were white, but then also Black, Hispanic, and other. They lived in 20 different states. Around 65% of them had research involving HIV. Half were harm reduction, and others were drug prevention. So what were the most frequent items reflecting moral obstacles for moral distress? I know some participants had given false answers to get into the study. I did not believe some participants really understood the research they agreed to participate in. And a lot of these came from the focus groups, right? That this is where we got the language from. I believe that offering money made some participants ignore the risks of the research. I could not provide participants with the service referrals they needed. I could not correct a problem in how the research was conducted, and I believe the research screening criteria excluded people who should be in the study. So these were the top ones. I forget, we had a lot more, but these were the top concerns that they had that we labeled as indicators of moral distress. We also had questions on burnout, which is part of the definition of moral distress. I was emotionally drained at the end of the day, 50%. the job was very stressful, another 50%. I worried the job was hardening me emotionally. I mean, these are high numbers for people who are working in this area. I was overburdened by the demands of my job, and I questioned the meaningfulness of my job. And, you know, we're not out there, and they are. And I think that, you know, that's, you know, we kind of forget that once you become a PI. I'm sure a lot of you are out there now. Okay, so these were some of the moral science practice dilemmas that I talked about. This had to do with recruitment. I won't go out to sell a study to drug users if I don't trust the investigator. So you can imagine, I'll talk about how that impacts the validity of research, and we don't even know that they're struggling with this. I find it hard to sell a study to drug users when I do not believe this study will produce useful results. These are a lot of people are saying this. I exclude drug users from participating if I believe they are lying about what drugs they use. That was, you know, I spoke to a lot of people about that, and they felt they knew more than the inclusion-exclusion criteria, which they felt were not even valid, that they knew these people. And they knew which drugs that, you know, they could see lines on somebody, so they maybe knew they were injection drug users, and the person was saying, no, I'm not, you know, just to get into the study. I discourage drug users from participating in a study if I believe it will not be good for them. Others, moral versus science practice dilemmas included their belief about that affected scientific integrity. Even when it's not part of my job, I counsel participants about their drug problems. Now, why does this affect scientific integrity? Because if you're studying what the problems are, and at the same time they're getting counseling, you know, that's, you know, and you can imagine these people are living in the community or are there every day. They don't even have to live in the community, but they're there every single day, so they become part of that community, and they feel they have knowledge because they're part of a research institute, and that they have to give it away. The questions I am told to ask unintentionally give away the drug inclusion criteria. So everybody knows, and if they want to get paid, they know what the answers are. I use my own money to buy coffee or other small goods to keep drug users interested in participating. So here we're talking about constantly getting the numbers because they're pressured. So now they're using their own money to do this. I find it difficult to protect participant confidentiality when people in the community know what type of study I'm working on. So this is a lot. And it really, if we don't know about it and we don't ask the people who work for us what's going on, we really don't know how good our research is. Okay, and then we did a research mistrust. So 51% endorsed 2 or more of these items, even though it looks like maybe it's only 30%, but 2 or more endorsed. Some people in the community distrust me because I am a worker. And most investigators do not care about participants. They just want to get the study done. Drug users in poor communities are paid less for being in a study than middle-class drug users. So, you know, here are the people that know our research the best, and this is what they think of us. Drug use, and this reminds me of what Tom was saying, right? Drug use-related research that is conducted in poor communities will mostly benefit middle class, and research exploits drug users who are desperate for help. So you can imagine what it feels like to be working on these things and feeling that you're not doing good, you know? And then what about their organization? Oh, their organizational research ethics climate was terrific. So why didn't it help the research trust, you know? So yeah, they teach me about this. Yeah, they teach me about that. I know all about it. Again, just like our city. So what were the hypothesized relationships among moral distress? So greater moral practice dilemmas was associated with higher moral distress. So the more they were deviating from the science values to do the social justice values, they had more moral distress. Both moral distress and moral practice dilemmas were positively correlated with research mistrust. So I don't know which came first. Moral distress, moral versus scientific practice dilemmas, and research mistrust were negatively correlated with organizational research ethics climate. So it did work to some extent, which was good, thank goodness. And so, just for discussion, so approximately half of the community research workers experience moral distress. They also prioritize social justice ideals when these conflicted with some of the scientific procedures. They endorsed research mistrust items, with 75% endorsing an item indicating substance use HIV community research was exploitative. But despite that, the majority reported high levels of organizational research ethics, climate, and support. And also, I didn't report on this, very high in research commitment. They wanted to do good. So one of the take-homes is community-based substance use HIV researchers are moral agents. Just like we talk about, our research participants are moral agents, responding to our research in ways that reflect their values. They attempt to achieve an overarching social and scientific moral good. They feel a moral responsibility to address social injustices experienced by vulnerable participants. And moral distress arises when they cannot actualize these values via their work and can result in their following one's personal moral compass when confronted with these personal versus scientific ethics dilemmas. So now when I've gone to, give this to PIs. And so I always, I emphasize the challenges to research integrity because that's what they're really, some are interested. This is an ethics group. We're interested in something else. But they become alive in this presentation when I talk about challenges to scientific validity. So why isn't a supportive research ethics climate enough to reduce moral distress, moral practice dilemmas, and research mistrust? What do community researchers have to teach us about the vulnerabilities in our traditional community-based research designs? These are the things the principal investigators should be thinking about. So what is the risk to generalizability? Poor ecological external validity of our screening protocols leads to exclusion of the this is what they believe. We're excluding representative populations because, we have these very strict, and we may not be in the communities itself to really know. It alerts drug users to inclusion criteria, and they're so smart. They're so savvy, right? They're so savvy. They know what we're doing. But when I was interviewing people who use drugs, it was great because they would tell me about every single study that was going on in the city. It was kind of gossip. I could learn what NYU was doing and Columbia was doing and how they felt about it. Inclusion of subjects misrepresenting their drug use and erratic application of screening criteria to get the numbers. There's also risks to scientific validity when there are these moral versus scientific practice dilemmas. So research designs with little perceived participant community benefit, threats to internal validity if the community workers feel responsible to counsel or provide referrals. Threats to generalizability when recruitment levels are lowered if the community-based researchers do not believe in the study's scientific or community benefits. So they're kind of torn. They don't want to include people who they think won't benefit. They want to refer them out to treatment, and at the same time, they have to get the numbers. Inattention to dual role burdens perceived by community workers and ignoring their feedback threatens research integrity. We found that they feel that they may be exploiting the community, they have moral distress, and there are uncorrected problems with research implementation. So what are the implications for organizations? That community-based researchers have valuable expertise in research challenges in the field that can strengthen scientific validity and integrity. their jobs lead to vulnerability to these moral practice dilemmas and to moral distress. They make efforts to overcome obstacles to actualizing their perceived moral responsibilities that threatens the scientific validity, integrity of our studies. So how do we do good community-based science? Well, we have to include community-based researchers in the design of recruitment, inclusion, exclusion criteria, I don't know why that question mark is there, and other community relevant research procedures. And, so setting aside regular team sessions for debriefing and feedback, and obtaining firsthand knowledge of the research community to enhance scientific validity in research. Many of these people say, yeah, the white researcher is sitting in the office, the person with the grant, they have no idea what's going on, and, and sometimes they're criticizing the research worker for being an Uncle Tom, or you're hiding the face of the white researcher, even if it's not a white researcher, they think it's a white researcher, white researcher, male, who's sitting in that office. So that's their impression anyway. And so, getting out into the community, obviously, or knowing how to do it is important. And I think that's it.